Good afternoon. This is a 48-year-old Caucasian female who presents with a 3-month history of constant and debilitating fatigue associated with depression, decreased activity levels, increased appetite, no inciting events, unrelieved by extra rest. The timing is not related to seasonal association, and she had a chief complaint of, quote, "I'm feeling fatigued." Her past medical history: she was diagnosed with depression 1 year ago from her primary care physician. No known allergies. She does not take any herbal supplements or over-the-counter drugs. She does take estradiol 1 milligram PO. It's cycled on 21 days on and then 7 days off per 4-week cycle. And she takes that because she had a hysterectomy 9 years ago related to endometriosis. And so she is in menopause. Family history: mother died at age 57 of a motor vehicle accident. Dad is 75. He's alive and in good health. She has no siblings. Also of note, she does have a son who suffers from depression as well, and he did try to commit suicide 3 months ago. She lives alone, no recent travel. She does not use illicit drugs historically or current, no alcohol use. She is a half a pack a day smoker for the past 20 years. Upon review of systems, she reports generalized cold intolerance and malaise and weight gain. No fever, chills, or headache. HEENT, she denies any symptoms except for hoarseness in her throat and neck swelling. Respiratory: denies cough, dyspnea, wheezing, or shortness of breath, and cardiovascular: denies any chest pain or palpitations. GI: denies nausea, vomiting, diarrhea, constipation, and GU is unremarkable. Musculoskeletal: she denies any arthralgias and myalgias, or she denies any vertigo and syncope, and upon psychiatric questioning, she denies any suicidal thoughts. Her vital signs, upon physical exam, she is sitting quietly with flat affect. She does have poor eye contact. She's alert and oriented and answers questions appropriately. Her vital signs are within normal limits. She is 5'4" and weighs 240 pounds, so that puts her at a BMI category of 41, which is considered the extreme obese category. Her skin is smooth and dry. Her hair distribution is full, scalp atraumatic and normocephalic. She does have generalized edema to the face and bilateral enlargement of the thyroid gland. It is non-tender, and there are no cysts and no nodes. Respiratory: chest is symmetric, respirations are symmetric, and bilateral breath sounds are clear to auscultation. Heart rate, regular rate, no S3, S4, no murmurs. Bowel sounds are active ×4, soft, non-tender. Peripheral vascular: she does have bilateral lower extremities edema at a 2+. She stands and walks without difficulty. Upon neuroexam, her speech is slow and slurred, and she does have bilateral deep tendon reflexes. The Achilles deep tendon reflex is delayed at 1+. So we did some lab testing on her. We did a TSH, and that was 5.18, which is high. That cost $17. Also did a thyroxine free T4, which was $44, and that was low at 0.55. Went ahead and did a CBC as well. The cost of the CBC was $17, and did not include a diff with that. Her H and H were both low at 10 and 31.8%. So differential diagnosis: first one, hypothyroidism; second, Hashimoto's thyroiditis; third, fatigue syndrome; and fourth, infectious mononucleosis. What her final diagnoses became were 1, hypothyroidism; 2, depression; and 3, obesity. So how did I rule in and rule out those? Rule those in and rule those out. First of all, with Hashimoto's thyroiditis, the patient presents closely to hypothyroidism with fatigue, constipation, dry skin, weight gain. My patient had all of those except for constipation. Also with Hashimoto's thyroiditis, you have an elevated TSH, and your T4 will either be normal or normal or low, and again, hers was low. Another thing with Hashimoto's, the CBC can reveal an anemia, which mine did. The biggest thing with Hashimoto's is how I ruled it out is you order these anti-TPO, which is thyroid paradoxase, and also anti-TG, which is thyroglobulin. Those are antibodies which will confirm the autoimmune disease of Hashimoto's, and that was not offered on the DXR, so that was ruled out. Secondly, fatigue syndrome, the diagnosis of fatigue syndrome, as she had all the pertinent positives with lack of energy, difficulty doing simple tasks, mental and physical exhaustion. However, upon the TSH and T4, it gave us a reason for the fatigue syndrome, so I was able to rule out just generalized fatigue. Infectious mononucleosis was shortly considered because of her extreme fatigue, but she also had all of those pertinent negatives of no fever, no tonsillar exudates, no posterior cervical lymphadenopathy, no headache. And so that diagnosis was ruled out. I did do a monospot. Don't know if it was necessary, but I did it. Cost of that, $40, and that was negative. Okay, so my ruling in of hypothyroidism was, of course, the TSH and the T4, and then also her enlarged thyroid. The cold intolerance, facial edema, dry skin, and nails, slow, deep, tendon reflexes, and her slowed speech. So that was a confirmation. Depression was confirmed because of her previous diagnosis, and also the recent event that she had with her son where he committed suicide in the past 3 months. I would say that that would predispose anybody to some sort of mental anguish, including depression. So that was confirmed. And then obesity, of course, with her BMI being so high at 41. And so that was the confirmation of that diagnosis. So how do we treat all these with hypothyroidism? That would be addressed through lab monitoring and medication. I'm going to start her on levothyroxine, 1.6 micrograms per kilogram. In calculating her dose, she would start out at 175 micrograms per day. Her TSH wasn't extremely high, so I don't know, maybe 175 will be good, will be a good dose for her, but what we would do is bring her back in 4 weeks and recheck her TSH and T4 and see if it's made any changes. You can do dose adjustments, 12.5 to 25 micrograms a day, and so that's what we would do if we needed to. Once she's euthyroid, I would have her come back in every 3 to 6 months, at least for the first year, just to check in with her because she is a sensitive case. Pearl of wisdom, teach your patients to take levothyroxine on an empty stomach first thing in the morning, and that's will increase the absorption of the meds. The obesity, we would address it through diet and exercise counseling, perhaps putting her on a 2,500 calorie a day diet of low fat, increased fiber, increased protein. I did read that you could do decreased carb diet. I don't think that's a good idea for this patient because of her decreased energy level, and I've been on a low carb diet and I know that it doesn't make you feel good at all and you have no energy. So I would talk to her about complex carbohydrates, teach her how to incorporate some of those into her life. I would assess her level of desire. Okay, what do you want to do for activity? Is it possible that you could start walking around your neighborhood, getting out of your house? You do live alone, just maybe walking with a friend, just kind of see where she's at. So that's how we would deal with that. Depression would need to be addressed through counseling and or medication monitoring. We could do an SSRI like Celexa 10 milligrams PO daily, but I would, before jumping right into that, I would kind of see if she wanted to wait and see if the change in her thyroid affected her depression, and if so, then she might not necessarily need to be on the SSRI, but we could have made that decision together, a shared decision. Smoking, we would address through smoking cessation education and see her desire to quit, of course. As far as the symptoms from hypothyroidism, you can kind of monitor and watch those, like the fatigue, the dry skin, the low H&H. As she becomes more euthyroid, they may pan out themselves, so there would be all things to keep on her problem list and on their radar. A couple of other things that I kind of learned. The cause of anemia and hypothyroidism is super complex, but one of the reasons is people who are hypothyroid don't make enough gastric acids, and you know that gastric acid is essential for uptaking all the minerals like calcium, iron, magnesium, and zinc. And if you have hypothyroidism, it alters the absorption of those nutrients, so it leads to anemia. So kind of makes a reason for why you'll see anemia with hypothyroidism. Well, let me do my critique. I didn't think it was necessary to do the monospot. I jumped the gun on that for a mono test. I should have looked at the picture a little more clearly instead of just jumping right into thinking it was mono with the fatigue. I did test for ferritin too, which was a $36 test. I don't know if that was necessary. I was thinking because she's anemic, maybe she has iron deficiency anemia. Hers was normal, of course, so that kind of ruled that out. Thyroid ultrasound, I went ahead and did that because I was thinking like zebra. I was thinking, what if she has thyroid cancer? It was only $107, but it probably for a patient would be nerve-wracking if they know why you're doing it. Again, maybe slowing down and looking at the whole clinical picture before jumping right into that. I did say that was $107. I should have asked her what her weight gain was. Like she said, I've gained weight. I should have said, well, in what period of time? If I could find out that information, that would give me a nice baseline from which to work when I'm doing my diet and nutritional counseling with her. And then last pearl, things that you can monitor when you do have a patient who has primary hypothyroidism like my patient. You can monitor a lipid panel because they can tend to have elevated total cholesterol and elevated LDLs. Also the anemia that I talked about already, and you would want to monitor vitamin B12 and D. They can be reduced with hypothyroidism. You want to monitor sodium and magnesium levels, of course, because your electrolytes need to be stabilized. And also assessing inflammation in her body through monitoring a CRP. Maybe we could do a baseline with her with those labs and then recheck annually, just seeing how she does with her progression and that. Anyhow, that's all I have. Thanks.